It's our great honor to be here and present two rare cases from our Hawaii hospital. And we are Dr. Lo and Dr. Fan from the hypertension department of Hawaii Hospital. And today our presentation will be performed by us and directed by Professor Huimin Zhang, who is not available here because of emergency tasks. And our presentation is about two patients with a horrible urination with paroxysmal hypertension, and there is no conflict of interest. And firstly, I will invite my colleague, Dr. Fan, to introduce the medical history of these two patients.
Distinguished Chair and dear delegates, we'd like to report two cases administrated in our hospital at the same period. With case 1 is a 40-year-old woman with a 2-year history of episodes of high blood pressure, severe headache, pale, cold sweating, and her symptom onset within 1 to 2 minutes after urination, with an elevated blood pressure from the normal level to 180 over 120 mmHg, and her symptom only lasted for a few minutes and relieved spontaneously. However, before she admission, she complained of a 1 month history of aggressive symptoms. And in terms of physical examination as well as regular examination, her previous history and personal history has nothing special. Her father had a history of hypertension, and her blood pressure is 130 over 80 mmHg with a heart rate of 70 beats per minute, and nothing special observed on her ultrasound examination as well as urinalysis. Case 2 was a 50-year-old man with a 10-year history of episodes of hypertension, and his symptom also onset within 1 to 2 minutes after urination, especially after the first morning urine. And his blood pressure is a little bit higher than the case 1, with 200 to 250 over 100 to 120 mmHg, and his symptom is also lasted for a few seconds to 5 minutes. But what strikingly impressed us was that he was very nervous and scared of urination. And in terms of physical examination and regular examination, we found that he was a little bit overweight with a blood pressure of 146 over 68 mmHg. And the ultrasound examination revealed his intraventricular symptom is a little bit thicker of 30 millimeter, and he has a left ventricular diastolic dysfunction. A quick summary for those two patients that they have a post-maturation symptom with paroxysmal hypertension and severe headache, palpitation, and sweating. However, their symptom only lasted for a few minutes and recovered to the normal level spontaneously.
So now we have learned the outline of these two patients' medical history. So my first question is, what's the possible diagnosis for these two patients, and what are the further examinations if you are the doctors? So who wanna ask? Okay, please.
Microphone. There is somebody behind you. Sorry.
I would probably do a bladder endoscopy and an echography of the lower urinary tract.
Okay, there was another suggestion just behind Professor Stassen.
From the presentation, being a primary care physician and a clinical hypertension specialist, I would say, it seems I'm facing a case of fuchromocytoma like symptoms. Then, okay, everything is okay in front of me. Okay, let me go further. Is there any complications, anything else? I may give the patient for ambulatory blood pressure to take home, as far the office blood pressure is not that high, just to give me more clarification about this queerful fuchromocytoma. In addition to that, definitely I'll go for fundi to look for any what seems to be masked hypertension, if maybe I may say some findings, some early changes of hypertensive fundi changes. In addition to that, I may go further, really, other than the ambulatory blood pressure and having the fundi exam. I haven't heard anything about the ECG findings. That just the echo. I mean, just to make it simple for primary care physician to give the suspicion earlier, that's it.
Okay, could I for 1 second criticize, if I may, Professor Stassen's suggestion? With these symptoms, I would be very careful to proceed to cystoscopy, because we know that if our second speaker is right, any procedure in such a patient, anesthesia, or even procedure, or pressing on the source of excessive catecholamines could really cause a storm and a very severe situation. So I would want to first measure things laboratory before I proceed to any procedure at all, because I have seen a tragedy with a patient like that.
Totally agree. I'll go with my suspicion of pheochromocytoma first to affirm it together with complications.
Okay, the microphone for the lady on the end of this row, please.
Thank you, Prof. Actually, I'm also a family medicine specialist, so I totally agree with Prof's suggestion. On top of want to assess for the dark organ damage, I also would like to confirm the diagnosis. But of course, because of episodic hypertension, together with means the severe headache and the adrenergic response, the pheochromocytoma, I would like to order this 24-hour aldosterone and then catecholamine, the urinary test as well. And I want to do the renal profile as well, the albumin, to assess for the dark organ damage. So we have to, one to confirm the diagnosis, on top of one to rule out this is a really sustained hypertension. Then we have to look for the dark organ damage and confirm the diagnosis.
Okay, so we have similar comments. Any other additional comments that don't confirm the same? Yes, Professor Stassen is not giving up.
No, I would like to challenge the chairperson.
Yes.
So if you don't stimulate the bladder, how can you have an increased excretion of catecholamines? So one way or another, you have to document increased excretion of catecholamines.
Sure.
And how will you do that if there is probably you need 24-hour
urinary
24-hour urinary collections.
We would, in our center, we would do 24-hour urinary excretion of every catecholamine we can measure, and that would give us first indication. And they would, with this presentation, they would be sky high, I think. Okay, I think we need to now see what happened really.
Okay. So, because of the typical symptoms of paroxysmal hypertension with palpitation and headache and sweating, and we suppose that the pheochromocytoma or paraganglioma are highly suspected. So, is that the truth? The diagnosis of pheochromocytoma and the paraganglioma, we need the biochemical tests, as have been mentioned by one of the professors, and also the imaging studies. So let's have a look of the results of these tests.
Yeah, in terms of biochemical testing of PPGLs, we performed the plasma catecholamine examination on the symptom attack of case 1 for 4 times. And in the last 2 examinations, we observed a slight elevation of the norepinephrine and epinephrine level. And also we did the plasma-free metanephrine examination, but nothing special observed. And we also performed the 24-hour urinary fractionated metanephrine examination, and we find a little slight elevation of the norepinephrine level. And in case 2, during the full examination, we find a very remarkable elevation of norepinephrine and epinephrine level. As well, we find around 4 to 7-fold elevation of the non-metanephrine level. And the 24-hour urinary fractionated metanephrine examination revealed that the norepinephrine elevated dramatically, and we also observed a near 1.5-fold elevation of the metanephrines.
So since the biochemical testing of the paraganglioma is positive, so the next question is, where is the tumor? How could we find the tumor? As we all know, the pheochromocytoma derived from adrenal gland, and the paraganglioma derived from extra adrenal chromatin cells. So so what's the locational examination, do you think? Is my next question.
Okay, so
Which
we
examination?
invite the audience to comment. Yes, we have the same discussant. Yeah.
I
Okay.
guess the next step, once a few is positive, I'll go for CT abdomen to clarify whether there is something organic which I can pick it up before to go for further workup. Maybe the CT will be the next step that I'm going to.
So what's your first test?
CT abdomen, I'll go for.
CT abdomen.
Yeah, for any
There is
intra-abdominal tumor. After any few, I'm suspecting and confirming by biochemical.
Okay. So we have another offer on the left. If you pass the microphone, yourself. Okay.
The patient's symptoms, according to history, I think it was induced by urination. So I think the bladder should be the first one to check. So I think the first examination method should be ultrasonography, and then CT may be needed.
Okay.
And finally, maybe endoscopy. Sorry.
Okay, so we have another two comments. First, can you pass the microphone behind you? Yeah. Yes, please.
I think, in my opinion, it can divide it into the non-invasive and invasive way of survey. So non-invasive, of course, we have to make sure this is really related to urination. I would like to do the blood pressure before and after the urination. And then after that, I will think the CT abdomen will be the first, because I think in the presentation already mentioned the ultrasound was normal. So I think CT abdomen will be my first line. But of course, from there I can identify the location. Then I only decide whether I want to do the invasive in order I want to confirm the diagnosis by doing the biopsy.
Okay, and another comment?
I agree with the CT angiography proposal, but in parallel or immediately after, I would go for some sort of scintigraphy. For example, MIBG scintigraphy, because first, it could be a very small tumor which is difficult to detect by CTA, and second, it will allow detecting additional associated paraganglioma elsewhere maybe.
Okay, so we have lots of very good suggestions. Tell us what you've done.
Okay, thank you for your answers. Since the symptoms attacked related to micturition, so we thought the tumor may be close to the urinary bladder. So we choose the ultrasound first because this is the easiest and the economic method. For case 1, the result of the ultrasound of the abdominal and the pelvic ultrasound is negative. But for case 2, we find nearly 35 millimeter size mass located in the anterior of the urinary bladder. So for the case 1, we have to ask ourselves that are we in the correct direction of the diagnosis? The case 1 is a middle-aged female patient with episodic hypertension, palpitation, headache, and sweating, but only slightly elevated MNS levels observed, and the pelvic ultrasound is normal. So is that possible that this patient has some kind of somatic disorder, including anxious or panic attacks, which is very common in the middle-aged female patient? So I want to know that.
There is some urgent comment. Okay. Urgent comment.
really, once I'm having ambulatory blood pressure done, then this will clarify the issue, and I cannot really imagine that being anxious panic after micturition will be a big deal. And if it is so, this means that I'm dealing with a urological problem that I need to solve it very urgently, and this will necessitate as well CT, abdomen and pelvis to be done. I do agree with ultrasound to be done for, but this will not solve the problem and will not answer the issue. Ultrasound has to be done just for a quick answer, but it will not tell me whether to go for CT or not. I'm going to CT, whatever the result of the ultrasound.
Okay, good.
I have a comment about the slightly elevated metanephrine. When testing for catecholamines, metanephrines, pre-analytic procedures are of extreme importance. Was the patient sitting or lying down? Was it cold temperature or was it a pleasant temperature? Was it a noisy place? Catecholamines and metanephrines are quite sensitive to pre-analytic procedures, which unfortunately are sometimes forgotten and not adhered to properly.
Yeah. And added thing with this is, of course, drug treatment. If the patient is on any drug treatment that could interfere with the measurements. Dr. Yan. Yes.
I agree with the presenting doctors that it's possible that this female patient had a panic attack, but even the ultrasound examination is negative. We still need to more accurate imaging to exclude the possibility of fecal tumor.
Okay, so what happened next? Tell us what happened next.
So, what's the next examination for case 1? The CT scan or the MRI? From the guidelines suggest CT rather than MRI as the first choice imaging study for thorax, abdomen, and pelvic PPGLs. So let's have a look at the results of the CT scan.
Yeah, we performed a CT scan in both these two patients, and the adrenal CT scan revealed nothing special in case 1, but after the pelvic CT scan, we observed a 8.2 over 10.5 millimeter mass located in the right back wall of the bladder with an increasing density after iodine injection. And as well in case 2, the adrenal CT revealed nothing special, but the pelvic CT scan, we can see that there is a big mass located at the anterior wall of the bladder.
So finally, the CT scan helped us find the tumors. But for the female patient, for the male patient, we find there is a tumor in the anterior wall of the urinary bladder, and for the female patient, the tumor located in the back wall of the urinary bladder, and which is rather small. So that can explain why we couldn't find it easily. So the next question is that enough for these two patients? What kind of other examination do you think they should have next?
Is there a comment from the audience? I think we already heard about another investigation before. Yeah. So do you want to repeat your verdict?
I think now it's time to perform scintigraphy, for example, MIBG scintigraphy, to make sure of the diagnosis, but also to be sure there are no additional lesions.
Okay, so do you agree?
Yes, yes. Okay. Yes, the functional imaging examinations is very important to the diagnosis of phenochromoscytoma and perigangliomas, because the functional imaging examination is complementary to the anatomic imaging, because it provides a functional characterization of the tumors. And also the functional imaging examinations is a whole body exploration, and is particularly useful for the evaluation of the multiple quality and or for the metastatic disease. And the functional imaging examinations contains MIBZ or the octreotide scintigraphy or the PET-CT. So let's have a look at the result of the functional imaging studies.
Yeah, we performed the octreotide scintigraphy and iodine-131 MIBG scintigraphy, and we found a non-focal area of increased trace uptake in the whole body survey of case 1. But in case 2, we performed the iodine-131 MIBG scintigraphy, and we find that an increased trace uptake of a near 30 millimeter size mass in the anterior wall of bladder. We can say it here.
So the big question arrives, why did the octreotide scintigraphy is negative in both patients? Actually, this is the biggest question we want to ask during the whole diagnosis procedures. And I want to know the answers from all the experts.
Okay, so expert 1 is ready.
Well, I think octreotide scintigraphy performs better in, for example, non-secreting head and neck paraganglioma, while MIBG is more for adrenal or maybe extra-adrenal pheochromocytoma with catecholamine secretion usually. But anyway, you're right to perform both because it depends from case to case, I think.
Okay, any other comments? Is this the answer you were looking for?
Yeah.
Good. Okay, they happy.
Right?
Answers? Okay, so what's next?
Okay. As we all know, the octreotide scintigraphy is a kind of somatostatin receptor scintigraphy, and the somatostatin receptor exists in many kind of neuroendocrine tumors, and but the sensitivity of the octreotide integraphy is highly body region dependent. And from this study of 48 SDHX gene-related PPGL patients, we can see the highest octreotide integrity sensitivity was found in the head and the neck paragangliomas, and the lowest was found in the abdomen paragangliomas and pheochromocytomas. And because of lacking of strong evidence, so the exact sensitivity and specificity of the octreotide scintigraphy need more large-scale clinical research, I believe. And the next question is how to explain the difference of the MIBZ result in these two patients.
Okay, microphone. Yeah.
There usually is quite good correlation between the level of secretory potential of the tumors and its and uptake. So I think the one with the minimally elevated metanephrin and the small tumor shouldn't be surprising that it was negative.
Okay. Any other? I think that's the only comment on this topic. So you can go ahead and tell us more once you get the microphone.
Okay. I agree with this professor. Okay, for case 1, a smaller tumor always leads to less function, so they may to lead to false negative of the MIBG scintigraphy. And also the MIBG, the sensitivity of MIBG ranged from 56 to 75% for paragangliomas, which means almost 1/3 of the paragangliomas patients is MIBG negative. So the diagnosis of these two patients is almost clear. It is urinary bladder paraganglioma, and the therapy strategy is surgery after medical preparation. So let's see the result of the surgery and the histological examinations.
Okay, and case 1 underwent the transurethral resection of bladder tumor after taking alpha blocker fentanyl orally for 4 weeks. And we also performed the postoperative histological examination, and we find that the tumor tissue composed of spindle-shaped slight metatypical cells and positive for cribogranin, as well as the immunohistochemical results proved the diagnosis of bladder periganglioma. And the case 2 also experienced the resection of bladder tumor and partial bladder resection after taking alpha blockers orally for 4 weeks. And the postoperative histological examination revealed the typical Zeppelin growth pattern of the tumor cells, as well as the immunohistochemical results proved the diagnosis of bladder periganglioma. And we followed up these two patients for around 1 year, and no paroxysmal hypertension symptoms onset again.
Okay. Now it seems a happy ending story, but the genetic test should not be forgotten because the guidelines has suggested that all the PPGL patients should have a genetic test. So we have a genetic test for the case 1 for the case 2 patients, because the case 1 patient refused to have genetic test, and the periphery blood test shows no mutation of PPGL related gene, including the RET, the NF, and the VHL, and the SDHB genes and other related genes. But for the tumor tissue tests, we find a RET gene 341 site G2A mutation. So could we can we tell you that there is no germline mutation, but somatic mutation exists? What do you think of the genetic test result?
Okay, so comments. Can we first ask about case 1? Just can you leave this microphone with? No. Okay, go ahead. It's difficult. Right. Okay, go ahead.
Okay. First, I agree it was important, but in order to look for SDHB, because it's associated with an increased risk of recurrence malignancy. But still, in some cases, you can have SDHD mutation or even SDHC. Did you look for these genes?
Yeah, all the SDHX series genes we have detected.
And then my second question is about the somatic mutation. Was this mutation described already in the past as a germinal mutation, or?
Is it a new mutation or already
Yes.
reported?
It's not a new mutation. It has been reported
But it was associated with a syndromic form of pheochromocytoma in the literature as a germinal mutation, or not?
Yeah.
Thank you.
Okay, my question was different. Can you pass the microphone back? Have you inquired more why case 1 refused genetic testing? Because people normally want to know, I don't know, but was there something in her family history that made her afraid of genetic testing? Maybe there was a similar case, maybe she remembered something about her parents, Have you tried to understand this refusal?
You know, in our hospital, we have a commercial panel for the hypertension related genes, and it costs it costs nearly.
So that's easy explanation.
Yeah.
You see, I come from the country where every test is for free. The medicine is free at the point of delivery, so I wouldn't understand it.
This is the easy
But
answer.
actually, in China, we also have the same problem as you have. Some family members, actually they are afraid of this kind of testing because they don't like that. Recently, we had Gitman syndrome family, but the family members refused to provide blood for genetic testing because they don't have any symptoms. They said that I would not do any genetic testing for that. And so that's still I think happens in China. If even we provide free testing, they may refuse. Yeah.
Okay, so can we continue? Yeah.
Okay. So let's have our discussion about the urinary bladder paragangliomas. As we all know, the urinary bladder paragangliomas is really rare, and it represents less than 10% of all extra-adrenal paragangliomas and only 0.06% of all primary urinary bladder tumors. Yet the typical manifestation of the urinary bladder paragangliomas include the hematuration, hypertension, headache, and sweating, and tachycardia or palpitation provoked by micturition or overdistension of the bladder. And the early diagnosis of the urinary bladder paraganglioma is necessary because it can lead to target organ damage, including heart, kidney, brain, and fundus of eyes, and also hypertension crisis is and also the catecholamine cardiomyopathy are the severe symptoms of the paragangliomas. And also, the most important is after the right diagnosis and the right correct surgery, the secondary hypertension is curable in all these patients. And how to diagnose the urinary bladder paraganglioma. We need the biochemical test, including the plasma and the urine metanephrines, and also the imaging studies, including the ultrasound, CT scan, and MRI, and also the functional imaging studies, including the MIBG, the PET-CT, or the optical site scintigraphy. And the treatment, all the patients with the urinary bladder paragangliomas should undergo operation as soon as possible. But preoperative medical manage at least for 7 to 14 days is very important to blockade the alpha receptor. The drug blockade include the alpha blockers as the first choice, and also the beta blockers to control the tachycardia only after administration of alpha blockers. And also the high sodium diet and the fluid intake should not be forgotten to prevent the hypotension during the operation. And the surgery strategy include the transurethral resection or the open resection, depends on the location or the size of the tumors. And the prognosis and the follow-up. Usually the urinary bladder paraganglioma are benign, so the most of the prognosis is good. Unfortunately, no specific pathological criteria for predicting malignancy, and there are some indicators of malignancy, including emission of adjacent tissue metastatic spreading, and long-term follow-up is needed to investigate for an recurrency. So let's have a conclusion of the urinary bladder paraganglioma. The urinary bladder paraganglioma is rare and is challenging to identify because of the various clinical presentation, imaging, and pathological appearances. And early recognition and early diagnosis and early treatment brings better outcomes. So, and all long-term follow-up is needed. So finally, I'll appreciate all the colleagues in our hypertension department in our Fry hospital who supported our presentation today. And thank you for your presentation. Thank you.
Don't go yet. So very, very exciting case, very unusual. And I think we have 3 minutes for a few quick questions. So there is one there, and I have one at the end.
What was the early presentation of this case, of these two cases, to the health facility? How did they present it? I mean, you are presenting us almost, I would say, for myself, straight ahead. I mean, track of investigation. But let me think of it very early in their presentation. There must be some tricky issues. It is not all of a sudden that they have such symptoms.
It's better to tell us what happened before admitted in the
Yeah. So before specialist care, before, you know, when they were maybe with their primary care physician, first presentation, yeah?
So in China, in hospitals outside Beijing or Shanghai.
Okay. Ready? Yeah.
They have visited some other hospital before the local hospital in China, but have no diagnosis and they don't know what happened about their disease. So finally, they were suggested to our hospital and transferred to our clinic. And after we consult the history of his symptoms, and we think that there might be a suspicion of the PPGL. So.
The question is, what was the presentation in the beginning? Why did you went to the doctor?
Okay.
Why did you went to a doctor?
Because they are all scared of urination when they, after the first urine, they feel very, because of the paroxysmal hypertension and headache, severe palpitation, so they are scared of urination, so they come to the hospital. Yeah.
How did they know that they are having high blood pressure?
Yeah, how did they identify high blood pressure when they urinate? So after.
Because of they have a symptom of headache accompanied with the hypertension. Yeah.
Okay, one more point there. Wait for the microphone. Wait for the microphone.
I would like to ask, because in your slide you mentioned the typical presentation, one of it will be hematuria, but in this patient, I think there's absence of this symptom. So would you like to give some literature? How many of them actually there's absence of the hematuria? Because if there's a presence of hematuria, then I think the diagnosis is very easy.
Actually, the literature about the bladder paraganglioma is really scarce or rare, and we searched for about 2 studies about this situation, and we found only near 50% patients they have the very typical post-maturation syndrome, but the other 50% they might just have a headache or hypertension, things like that. So yeah, maybe is it answer your question?
Microphone.
So I feel that actually it's not a typical presentation, but it's a little bit atypical presentation of the paracarcinoma of the bladder.
Okay, she made her point, and last question is from me. You said in treatment that you frequently give alpha blocker first, and when the patient is completely alpha blocked, you then add beta blocker. And that would be the standard. You didn't do it on this in these cases. If I understand correctly, you stayed with alpha blocker for both cases. Why?
Yeah, our first choice is alpha blockers. Only when the patients have tachycardia, we use beta blockers. Yeah.
Only if tachycardia, yeah?
Yeah, with tachycardia. The first choice is alpha blocker for the catecholamine crisis after surgery.
Okay. The belief in some other centers is that you block everything you can block.
Okay.
So you know, the ambition in our center, the ambition always has been that physician goes to the operating theater, and when they operate, whether it's cystoscopy or open surgery, the blood pressure shouldn't move an iota during surgery. That means you blocked properly. Very last comment, yeah? Very last.
Absence of tachycardia suggests that there was not enough alpha blockade.
Actually, in China, the current clinical practice is you start alpha blockade. If there is, as she said, if there is tachycardia, then we use beta blockers. Otherwise, normally don't. That's the current practice. We may probably consider a trial comparing with or without beta blockades. For instance, in the absence of tachycardia, whether beta blockade would be held for the clinical outcomes of operation.
I think patient is more stable if everything is blocked. Alpha first, then add beta, and you have everything blocked, and the patient is stable during the procedure. Right. I think great. I think we need to move on to the next case to be fair to the next set of presenters. So thank you very, very much. Very well done.
Thank you.